Okay, so can everybody see the main screen, the starting screen for the Centre for Clinical and Care Research?
Yeah.
Right. So hi everyone, welcome to the session. So my name's Claire Howard. I am a stroke specialist orthoptist at the hospital, and I'm just stepping in today for Heather, who leads the new Centre for Clinical and Care Research. Really just to sort of introduce the session. So the Centre for Clinical and Care Research is newly established, and it's really about providing some training and really sort of identifying clinicians who have an interest in research and developing their research skills and career opportunities. So Heather is the new centre lead, and she will hopefully be joining us towards the end of the session to say hello. The idea is that we deliver these training sessions live, and then we will record them so that people can actually join later on, or you can dip back into the sessions. And if you join on one of the sessions, we will, with your permission, add you to our mailing list, and that's where we will collect information about sort of where you're at in your research careers, but also we will share information about new training events and new opportunities. So on the research and innovation page, there is a new tab now for the Centre for Clinical and Care Research, and that's where all the links to the training will be, and that's where you can also sign up to our launch event, which is in June. And basically you'll be able to sign up and come along, and that's a face-to-face event, and that will be an opportunity to come and speak to other colleagues and come and actually share research ideas, meet with other collaborators, discuss what training needs you might have. So we'd really welcome people to join up to that face-to-face event, and anyone who hasn't signed up already, I would encourage you to do that quite quickly, because obviously because it's face-to-face, places are going to be quite limited, and it's already around about half full. So today's session is the second in a series that Ramona has already delivered a session on searching the literature, which will be available as a YouTube link on the website. And this next session now takes that a step further in terms of appraising the literature. And Ramona's quite happy for you to sort of stop her through the presentation and ask questions. So I'm going to pass over to Ramona now. Thanks very much.
Oh, thank you so much, Claire, and thank you for having me back as well. So yeah, as Claire said, so this session is about critically appraising the literature, and if you're new to this, it is a little bit full on. If you're not new to it, to be honest, it's still pretty full on. So I'm going over quite a lot today, and it can be a little bit overwhelming. But we'll send you the slides. There'll be a recording. And really the idea is to introduce you to critical appraisal and all of its different concepts, but it is just it's a whistle-stop tour really. So hopefully afterwards you'll be able to take this away, read up on it a little bit more thoroughly when you've already got a bit more of an idea. On the slides at the end as well, I've popped a few online resources and videos and books that the library have, so you can look into anything a little bit more. And of course, I'll always be at hand as well. If you do want more of an in-depth session on any of the aspects that I'm covering today, I'll be more than happy to do that too. So today I'll talk to you about what is critical appraisal and how we do it using some tools. I'm going to go over validity and bias in studies, and then an introduction to statistics, just focusing on randomized control trials really. I'll be pausing for questions quite regularly because there's a lot to take in, and we're going to have a break as well before we get into statistics. But as Claire said, if at any point you've got any questions, just butt in and stop me. I can't see any of you anymore, so I can't see if you're like looking confused. But yeah, so just feel free to shout out. So there's excuse me, sorry. So there's a lot of research out there. About 2 million papers are published every year, and not all of that research is great research, unfortunately. And so with so much research out there, we need to be able to determine what is useful to us to our practice and our patients, and what isn't. So critical appraisal helps us break down what a paper is saying, and then it helps us determine if that paper is useful for us. So to do that, we need to have an understanding of what's been done well in research and what hasn't been done so well. And so really critical appraisal, it comes down to 3 main questions about a piece of research. Is it relevant? Is it valid? And is it reliable? So why critically appraise? Well, when a research trial is undertaken, there are three possible explanations for its results, so for its findings at the end. One, that they're true. Two, that the findings represent random chance. And three, that the findings were influenced by bias in some way. So the second one, random error or chance, that can be prevented in ways such as increasing the sample sizes or the effect sizes. So the bigger the study, the less of a probability that the results are down to random chance, basically. While systematic errors or bias, they can be influenced by other shortcomings in the design, in the conduct, or in the analysis of a trial. And I'll go over some of those as well. So critically appraising papers, it doesn't only alert us to the limitations in published research, of course, giving us an idea of a study's strength and methodological robustness, but that process, it also underlines the importance of all of this from the beginning of the research cycle. And so in doing that, it supports you, our future researchers, to overcome limitations in study methodology in your own research as well. So I imagine as part of your research, some of you might be conducting literature searches or even systematic reviews. So you'll be incorporating quality appraisal and critically appraisal in there too. So what we have here is the hierarchy of evidence. I haven't included all of the different study types in this, but it just kind of gives a general idea of what type of research is considered better and more robust than other research. So at the bottom, we've got non-human studies. So obviously, they're not relevant to us, really. We can't take findings from rat studies and then apply them to our patients. Moving up, we have case reports, case control, and I'm going to go through all of these later on. And then at the very top, we've got systematic reviews and, of course, clinical practice guidelines, which for the most part, you'll be basing your practice on. And these are secondary evidence, so they've been pre-appraised, and they're based on the best available evidence, usually systematic reviews or randomized control trials. So I would really advise to become familiar with the hierarchy, just so that you can quickly identify, just from the title of a study alone, if it's going to be robust enough for you. So luckily, there are loads of tools and checklists to help us with critical appraisal so that we don't have to do it all on our own. And the checklists, they go through different questions to kind of consider about different studies. And they're really just designed to give you an idea, or to give you an understanding if a paper is of high methodological quality. So checklists, they'll answer some questions and then they'll have like yes, no, can't tell as the answer. They don't really come out with like a nice score at the end out of 10. So you do have to use your own judgment a little bit too. But they focus on the most important parts of an article. So it's definitely worth becoming familiar with the type of questions that they ask, some of which I'm going to highlight in a second. So I've got a few of the checklists here, I've linked to them. So I'm just going to go through them a bit. So at the left side, you can see there are generic ones. And so these are kind of like one size fits all type tools. But really the best tools are the ones that are specific to study types. So CASP is very popular and SIGN is as well. And so they have various checklists for lots of different study types like randomized control trials or cohort studies and so on. The Pedro scale for RCTs, I've included that one because this one is quite nice because it does give you a bit of a score at the end. So you can kind of tell, you know, if a paper is good enough based on the score, basically. The JBI has got many different tools as well, but it has one for opinion pieces, which I've highlighted. And opinion pieces are generally regarded low-level evidence, and there's not really a lot of tools for them, so that's why I popped that on there. And then the agree for clinical practice guidelines, so NICE guidelines and such. And you'd think that guidelines don't need appraising, but they do actually, especially ones that are done, ones that we create, in-house guidelines. It's always worth appraising those before sending them out into the masses. And then the AMSTAR for systematic reviews. I've also included a supplementary tool, a bit of self-promotion here, because that's one that I developed, and that's to be used in conjunction with any other checklist. So I'm currently helping people understand the issue of diversity and racial bias in research, and so that tool is specifically for appraising for anti-racism, so looking at underrepresentation of BAME participants and how different health outcomes between different ethnic groups have been interpreted. And then if a study uses more than one research method, there are mixed method tools too. So there's lots of tools to help you for appraising a paper. So on the screen, I've just got a few examples of questions that critical appraisal checklists might ask you. And they're mostly straightforward. You know, we have questions like, did the study address a clearly focused research question? Were the participants randomized? Because they should always be randomized into the intervention or the control group. Are the participants similar to the people in your care so that the results are generalizable? But there are a few questions regarding like statistics within the tools. So a basic understanding of statistics is necessary in order to critically appraise appropriately. So we can see here things about relative and absolute effect, attention to treat, power calculation, and p-values and confidence intervals. So I'm going to go over these later as well. So other things to think about are, did the research that you're reading produce new results, or do they reinforce existing evidence? But really, the ultimate question that we're going to ask ourselves when we're critically appraising is probably, should we change our practice based on what we've just read? So one of the key ways to evaluate whether a study is relevant to us and our practice is by looking at the external validity. So this is essentially looking at the features of the study, so not the conduct within the study, but the features of the study itself. So who was included in the study is the main thing really here, but also where was the study based, like what country or what setting, what was the study actually looking at, and what was the research question, or of course. So some of these tools that I just talked about, they might be nice and specific about these type of questions about external validity, and ask questions like, you know, who exactly was included in the research, where was the study held, and so on. And because you have to remember, you know, a study that's held in an Asian or an African country, it might not be applicable here. So these are the questions that you do really need to ask. But if a checklist doesn't ask these specific questions, then do remember that they are just meant as a guide. So if you want to include your own questions on top of them, then do go right ahead. That's perfectly fine to do. And then there might be other elements that you need to think about if you were going to apply the results to your own practice or your own research, such as, you know, will this new treatment in this study require more equipment? What about staff time and costs and training and all of that kind of stuff? And tools, they don't really always address those more practical elements, but do include it, do modify the checklist if you feel that it's necessary. So next we're going to have a look at internal validity. So this is less to do with the features of the study like external validity, but it's more to do with the choices made and the conduct within the research itself. So here we've got things like, was the sample size big enough? And because of course bigger sample sizes, less likely the results are down to chance. How did they recruit the participants? And that will of course certainly influence the results, you know, how they were recruited in the first place. Were the patients randomized and blinded, blinding so that they don't know if they were receiving the intervention or a placebo, which is definitely best practice so that they're not influenced by the results. Were the researchers blinded as well, because if possible they should be, and that's called allocation concealment. And they'll also be looking at things like the response rates, the dropout rates. So especially in randomized controlled trials, you know, if one group saw a higher dropout rate than the other group, then obviously that will impact the results. But it's also an indicator that something's gone a bit wrong internally as well. So keep a lookout for things like that. And then also think about, with your knowledge of the subject, was the follow-up rate long enough? So we're going to have a look at bias now, and bias are specific threats to internal validity. And what bias can do, it can skew the results. So it can either overestimate the results or underestimate the results as well. And so when you're looking at bias and research, what this does, it gives you the chance to really pull apart the study and ask, you know, did these results occur because of the intervention, like it should have done, or did something else happen in the study that influenced those results? So I've got a few examples of bias here, but this is not an extensive list, so I'm just going to go through these with you. So the first one we have is selection bias. So this is about how participants were recruited, so who was chosen to be in the study. So a study might have excluded people who were very sick or very old, and And in that way, the study participants might differ systematically from the actual population of interest. I always find it very important here to mention ethnic minorities or BAME populations. These groups are notoriously underrepresented in studies, though they exist in all populations. And so you can argue that this errs on the side of racial bias within selection bias as well. Next, I've got allocation bias. Oh, going a bit ahead of myself. So this is how were the participants allocated to their groups. So if they were given the placebo or an intervention. So allocation bias might happen if investigators or the researchers, they know or they predict which intervention they want certain participants to have because, they'll get more favorable outcomes. So to counter the risk of bias here, it's best practice to select and allocate participants completely randomly. Some ways of randomization are more appropriate than others. So you wouldn't flip a coin to randomize people into different groups. It should almost always be done by a computer generated thing. Observation bias. So this is where participants know that they're being studied, and so therefore they might consciously or unconsciously act a little bit differently. So this can be prevented by blinding the participants to the group, so they don't know if they're receiving a regular treatment, a new type of treatment, or a placebo, for example. Next is confirmation bias. So this means that a researcher might only see what they want to see, kind of cherry picking results maybe, in favour of the research question. So this can be limited by having more than one researcher. Confounding bias. So this is where confounding factors might influence the results. So for example, other health conditions that weren't studied, a person's age or general fitness will of course influence results. And randomization again helps with this, or restricting participants with identified co-founders, or just ensuring that the co-founders are equally distributed between the groups. So next we have a recall bias. And this is where the participants might not be remembering correctly or fully. So, if you're giving someone a questionnaire and asking them about a food diary that they, a food that they ate the last week, there's going to be a bit of recall issues there. So that will then lead to recall bias. So to counter that, really, researchers just might want to rethink their data collection approach, using a prospective design rather than a retrospective where they're relying on memories. And then finally, attrition bias. So this is where study participants are lost or they drop out. People die during studies, they leave, they move, all sorts of things happen. And then that leaves systemic differences within the groups. And that can be analysed, that can be fixed in the way the results are analysed later, with the intention to treat analysis, which I'm going to touch on later as well. So as I said, this is not an extensive list. It's just to make you aware that there are many factors that can influence results, not just the intervention of the study itself. So anything that makes you think, I'm not really sure if that outcome you found was because of the intervention or because of this other kind of bias, they're the kind of things that you want to consider when you're reading a paper. And then, of course, we want to look at the results themselves. So is everything properly described? Are the results significant enough? Have they been interpreted appropriately? What's important for me to mention here is correlation is not causation. So this means that just because two factors correlate doesn't mean that one directly causes the other. It can do, but it's not necessarily causation. So, for example, we've seen that BAME people are more likely to get COVID and die from COVID, but this is not because being a minority makes you susceptible. It's not biological, but there are other variables like housing, employment, structural racism, and so on. Definitely also have a look at the author declared limitations at the end, and that'll usually state any conflicts of interest or flaws in the study, but not always. So do have a look at things like the author affiliation to see if there might be any conflicts of interest there. So I'm just going to see if there's any questions so far before I move on to the next part. So do feel free to shout out. Lovely. So the next thing we're going to do then is we're going to have a look at some different study types now. So here's just the hierarchy of evidence again to remind you, and I'm going to start from the bottom, but I'm not going to include animal studies. So we're going to start with case reports and case series. So a case report is a detailed report on the profile of a single patient, and a case series is on a series of patients with whatever the outcome of interest is. They're not a trial, they're simply observational, and they usually cover quite rare events where there might not be a great deal of literature available already. So the strengths of a case report is that they're really fast and cheap. They identify rare manifestations. They're very observational, educational, and usually quite detailed as well, which is really helpful. However, their results are not generalizable because you can't, generalize what happened to one patient to the rest of the population. And that's because, of course, the samples are so small. Case studies, they're not usually followed up on, so we don't really know what the future outcome is. So it's not that helpful for that, really. So next we have the case control study. So this is a retrospective study. We're going back in time where we've got patients who've developed the disease of interest. So they're identified and their past exposure to any suspected factors is compared with that of a control group or a comparison group who don't have the disease. So in the example on the screen here, we've got cancer. So a suspected exposure here could be smoking, for example, and that will be examined in the group of interest, the cancer patients, and also the non-cancer patients as well. So they'll be examined for the histories and smoking, and then we can draw conclusions from that at the end. So, for example, those who have a history of smoking are more likely to get cancer in the future. Other than the interest, the cancer side of things, these two groups should be matched as closely as possible. So in age, sex, confounding factors, everything else, so that the results can't come down to something else really. So the strengths of case control is that they can be quick and cheap because we're not really getting anyone to do anything. We've already got our patients, we're looking into their histories. And for that reason, it's ethically safer because, again, we're not making anyone take any drugs or anything like that. And useful for studying rare diseases, definitely. Weaknesses is that they do rely on retrospective data, which can be unreliable. So recall bias, if we're asking a patient to remember something from a long time ago, we might not get accurate results. Inefficient for rare exposures because the chances of finding a group of patients that have also then been exposed to that rare exposure is not very likely. And prone to selection bias because you do have to physically select who you're going to put in which group. You can't randomize because you need the exposure group to have that group to have that disease of interest. So next we are looking at cohort studies. Excuse me, sorry. So in a cohort study, we've got a group of individuals who've been exposed to a risk factor and then a group who have not been exposed to that risk factor. And then they're both followed over time. So this is often years, it's a long time. And then to determine this kind of occurrence of whatever the disease of interest is. So the incidence of the disease in the exposed group is then compared with the incidence of the disease in the unexposed group. So in our example, we've got our group of smokers. So it's kind of backwards from a case control study, really. So we've got our group of smokers and our group of non-smokers. They're followed over time, and then we can see, who's developed this disease. And just like in the case control study, except for our thing of interest, which is smoking in this case, those two groups should match as closely as possible so that the results can't come down to anything else, any other confounding factors. So the strengths of cohort studies are that, we can measure multiple outcomes because we've already got a group of people and also multiple exposures as well. So that's very helpful. They're really good for measuring rare exposures like occupational exposure. So if you've got people working with a certain liquid or gas or in an office or whatever, and then others that don't, we can follow those and see the different outcomes that they have. So that's very useful. And of course, measure incidence and prevalence. The weaknesses of a cohort study is that they are costly and very time consuming because they do usually take years. And because they do take so long, they are prone to loss of participants. People will drop out if a study goes on for a long amount of time. And so that's attrition bias. That will lead to attrition bias. Being in the study might alter a participant's behavior because usually in a cohort study, if you're being followed for that long, it's a little bit difficult to keep the participants from knowing what group they're in, what's being studied. So they might, consciously or unconsciously kind of change how they act. And and not useful for studying rare outcomes. You know, if you're already doing a trial for a bunch of years and then the outcome doesn't happen because it's so rare, you know, a cohort study would not be appropriate for that. So next we have randomized control trials, and this is when 2 or more interventions are compared, and this is really considered the gold standard in clinical trials. So it's the highest in the hierarchy of primary studies, and we'll have used randomized control trials for the COVID-19 vaccine trials, for example. So here we have a group of patients who are randomly assigned to either the treatment group, which receives the intervention, a new drug or whatever, and then a control group which doesn't receive that intervention. They might receive a placebo. And then they're followed over time in the exact same way, and then the results at the end are compared. So randomized control trials are very strong studies, and this is because bias is really minimized as much as possible because we've randomized our participants. Usually the participants will also be blinded, so they don't know if they've received the placebo or the drug, of course. And they can determine if there's a causal relationship between the exposure and outcome. And as I said, they really are the gold standard for effectiveness in interventions. However, they are very expensive. They usually take a long time. You require lots of participants. There are ethical issues, of course, in different ways. You know, if you've got a new drug that's never been tested, of course, and now you've got a bunch of volunteers that you're going to stick some needles in. There's ethical issues around that. But also, you know, you might not be providing the best care for somebody. They don't know what it is that they're receiving. So lots of ethical issues around randomized control trials. They're very impractical. They require a lot of follow-up a lot of the time. And they might be prone to volunteer bias. So this is when volunteers are somehow different to the general population. So for example, if we were trialing something like a new health supplement, then the volunteers that might be interested in that study might already be a bit healthier than the rest of the population anyway, and that's why they wanted to apply. So they can differ a little bit from the general population. And then at the very top of the hierarchy, we have systematic reviews. So this is the identification and synthesis of all the literature available from whatever topic the review is looking at. So the evidence itself, it's picked out, it's sought systematically, and then its strength, validity, and reliability is determined through this kind of really extensive critical appraisal process, really. And then at the end, you've got a little systematic review of the literature with recommendations and such. So systematic reviews are very strong. They review all of the high-level evidence on whatever subject, and bias is minimized because there's all this predetermined criteria. Each article will be critically appraised separately to minimize bias. And systematic reviews, they really do help us in making decisions, making clinical decisions. They are at the top of the hierarchy, and we need those really to further our practice. They are very time consuming, however. A lot of people underestimate how long it takes to do a systematic review. It's not just a couple of weeks, it can take years. And we need multiple researchers on a systematic review to minimize bias. You need 2 people to go through all of the processes. And unfortunately, they can be poorly done. You know, I've just been harping on about how fantastic they are, and we all base our clinical decisions on them. But unfortunately, especially in the last few years, loads of systematic reviews have been churned out. Some of them haven't been done that well. And of course, because we think that they're all fantastic, clinical decisions might be based on systematic reviews that haven't been done that brilliantly, which is why it's still important to appraise them as well. So while quantitative research focuses on numeric data, there's also qualitative research designs, and these aren't in the form of numbers. So these more capture underlying beliefs and opinions or motivations of different groups of people, and they can help describe behaviors and lived experiences behind the numbers, really. It provides more insight into a problem, but they're just as applicable to clinical trials, and they really enable an in-depth understanding of a problem that quantitative research alone can't do. So they can help us answer the why questions through the experiences and opinions. And they can also identify themes that we might not be able to see just from numbers alone. However, they can't produce an effect size, because we're not looking at numbers and there aren't nice little boxes to pop everything in. It's more themes. And so therefore effect sizes can't really be produced in the same way as with quantitative data. So along with all the study types, you'll probably see other bits of terminology as well that are used to describe research designs in the titles of different papers and stuff. So I picked out a few here. So we've got a cross-sectional design, and what this does is it provides a snapshot in time of the whole study population at a point in time. So it doesn't determine cause and effect. It's just observational. So, and it's usually to determine the prevalence of something. So, for example, the prevalence of COVID-19 in a certain population or smokers in a certain population. So it doesn't give us the reason why or what happens because of it, just the numbers alone. Then we've got a longitudinal studies, and they cover just a long period of time. Pretty simple. Prospective and retrospective. So if a study is retrospective, it's looking at past data and analysing for it. So for example, attendees to A&E presenting with head trauma, you'd be looking at past data for that. And prospective studies collect data as the study goes on, like with a randomized control trial, for example. The data is collected as it happens. And then quantitative and qualitative, we've just gone over that. Facts and figures for quantitative and the hows and whys with qualitative. If there's any questions so far, now is your chance to speak up. But if not, what we're going to do is we're going to have a little 10-minute break, I reckon. So starts quite early with a break, but the next part that we're going into is statistics, which is quite full on. So I thought I'd stick a little break in here. And while you're on your break, while we're on our 10 minutes, have a little think about these questions that are on the screen, and I'll give you the answers after the break as well. So if we can come back at 45, if that's okay with everybody. And in the meantime, if anybody does have any questions, I'll be here too.
Ramona, there is a couple of questions. There's one in the chat from Louise. And,
oh, fantastic.
Samantha's got a hand up as well. So, Louise, do you want to just ask your question?
Hi, yeah. I was just wondering if there's any purely qualitative critical appraisal tools.
Yes, yes, there are. Right. There are quite a few actually, and in fact what I'll do is I'll pop them onto that slide and then send that through for you. Definitely.
Perfect, thank
you. Samantha?
Hi, can you hear me okay? Or
yeah.
Oh yeah, sorry, I was just technology messing up my microphone then. I just wanted to ask you about pilot randomized control trials, because obviously I've been finding, with things like COVID-19, for example, lots of people are trying to rush out studies or justify why they should be able to do larger control trials, etc., etc. And I've even seen systematic reviews where really, when you look at the studies they're including, a lot of them they might have to include pilots, RCTs, just because they do, and it can be a bit tricky because that that's always going to be an underpowered study. But how do you take that?
Well, I mean, to me, pilot trials, they're done before the main trial, so they're really kind of designed to support the development of a future trial. Sometimes they're called feasibility studies as well, and it basically is just to see if those studies, if it's feasible to do a big study from it. So I mean, I wouldn't, if you were doing something like a systematic review, for example, including a pilot trial, I don't think would be best practice to do, because you are expecting another trial to follow up on that, really. But sometimes there is no choice. If there isn't enough data on something, if there isn't enough research on a particular topic, and all you have is pilot trials to work with, then that's all you have, and that's what you have to go for, really. But I think in general, we try to avoid basing any decisions on pilot trials and wait for the full trial, definitely.
Yeah, thank you.
No worries.
Right, lovely, thanks. Shall we go to the break then?
Yes.
Questions.
Let's do that. So 45, did I say 45? Yeah.
Yeah, 45.
Lovely.
Yeah. Great, see you soon.
Thanks. See you in a bit. I'm just going to turn my camera off. So what I'll do is I'm just going to carry on. So before the break, it's like a little TV show. So before the break, I popped some questions on the screen. I'm not going to get anyone to shout out the answer. I'm just going to go through the answers. So don't worry about that. So the questions that we looked at are, why would you need to blind participants to whether they are in the intervention or in the control or placebo group? Why is it important to include BAME participants in a study trial? What evidence type is at the very top of the evidence hierarchy? And why is a long study potentially problematic? So let's have a look at those answers. So blinding participants so that they're not sure whether they're in the intervention or control group. We do this so that they're not influenced. So observation bias comes into this, where if a participant kind of knows what group they're in, they might consciously or unconsciously act a little bit differently. Why is it important to include BAME participants in trial? Just quite simply so that the results are applicable to those populations. We want our participants to include we want them to reflect the real population, the real study population, so that those results are generalizable. And BAME participants, they exist in all populations, so they definitely should be included in all trials as well. What evidence is at the top of the evidence hierarchy? Clinical guidelines and systematic reviews. So I always pop them on par with each other. I think actually clinical guidelines do come higher than systematic reviews, but for the most part, guidelines are based on systematic reviews anyway. So I pop them both equally at the top of the hierarchy myself. And why is a long study potentially problematic? And that is because you might lose participants along the way, whether they drop out or they die. They just don't, they don't want to be part of the study anymore. And so that can then lead to attrition bias, where the groups just differ systematically somehow. Lovely. So now that we've gotten over the first part of the session, we're going to now have a look at some statistics, and I am focusing on randomized control trials really. So there are other bits of statistics for systematic reviews and so on, but randomized control trial, being that they are the primary, the best primary study, I thought that would be appropriate for this. So what we're going to go over in this section is statistics for randomized control trials, as I said. So the different ways the results might be reported in a randomized control trial. So we've got relative risk, absolute risk reduction, relative risk reduction, number needed to treat. And then I'm also going to touch on p-values and confidence intervals as well. And they're just so that you can understand the results a bit better too. So I'm going to explain what all of these mean, but for critical appraisal, you don't really need to know the background of each statistical concept, so you don't need to know how they're calculated. I do kind of touch on it a bit, but it's really not important. It's just to help you understand, what they mean and how they work really, especially because they do come up in critical appraisal checklists. So it is nice to be able to answer those questions with some degree of confidence. Just a disclaimer, I am not a statistician. I'm not an expert on statistics at all. I am constantly learning about this myself. So if you do have any questions about any of this, I might not always be able to provide you with an answer today, but I'll go away, I'll dig about, and I'll definitely get back to you all as well. But of course, I'll make every effort to answer any questions as best as I can. So as I said, I'm not a statistician. So when I'm looking at numbers in a research trial, I'll start off with these 3 questions. So first of all, was the sample size big enough? So I've mentioned a couple of times now that a trial needs to be big enough to be able to detect statistically significant results. And to answer one of your questions earlier, in fact, this is why a pilot randomized control trial, the effect sizes aren't usually big enough because they don't recruit a lot of people. And so the results could be put down to chance. So to see if a sample size is big enough, we don't just estimate, we don't just guess that a sample size was big enough. There is a power equation, and that lets us know if the sample size was big enough. So an author should write the power equation down, and it'll be displayed as a percentage. And it's a little bit complex and I don't really understand it, but a power percentage above 80% is considered strong. So if a power percentage 80% or over, then the sample size was big enough. They're not always published, the power equations. I kind of think sometimes it's maybe when the power equation isn't high enough, they just don't pop it on in the paper. But that's neither here nor there. Next is the duration. Was the duration of the follow-up long enough? And There is no statistical equation to work this out. You'll be glad to know. This just comes down to the intervention. So it comes with your knowledge of the intervention, really. So if you were looking at a study that was dealing with a painkiller, then the follow-up rate might only be 2 days, and that seems quite appropriate. But if you were looking at maybe like a wound healing intervention and they only followed up for 2 days, well, then, you know, and then it decided that the intervention was a success. Well, really, you might want to ask yourselves, should the study have kind of checked, you know, maybe a couple of months later as well, rather than just 2 days? And then, was the follow-up complete enough? So again, I've mentioned a few times that, especially during long trials, participants might drop out, and then that can change the dynamics of the results. And, you know, also there might be reasons linked to the trial itself, and that's why participants dropped out. So it's not good practice, surprisingly, for researchers to just ignore the dropouts and then just carry on with the trial without them, because that then leads to attrition bias. So what we do here is we use the intent to treat. So this is the standard practice, is to analyze results on an intent to treat basis. And that means that everyone who was enrolled in the study and randomly allocated, they are then included in the analysis, even if they dropped out. I'm not going to go into details of how they work it out, and I've got a little video at the end which can help you understand it, but it's just something worth watching out for. If an author has mentioned that people have dropped out, have a look to see if they use the intent to treat analysis as well. So next, you'll be looking at the results of a study. And as I said, I'm just concentrating on randomized control trials today. So the results in an RCT, it might be expressed in one of 4 different ways, either by relative risk, by absolute risk reduction, relative risk reduction, or number needed to treat. So I'm going to go through what each of these mean so that you can understand different results expressions a little bit more clearly. So we're going to use a fictional study to demonstrate this. So let's imagine that there's a study which trialed a new drug, and this drug aimed to prevent death among cancer patients. So we've got 100 people in our placebo group who didn't receive the drug, and 4 of those people died during the trial. And then there were 100 people in the drug intervention group, so they received this new drug, and 3 of the people of that 100 died. So they're the kind of numbers that we're working with from the beginning. Don't be overwhelmed by this slide. I'm going to talk you through it. So we're going to have a look at the 4 different ways that a paper might report those results that we've just found, and they're listed on the right side there. So as I said, for the purpose of critical appraisal, it's really not essential that you need to know the calculations around it all. They're just on the screen anyway. But a bit of a basic understanding might help you understand what the results actually mean. So first, we're looking on the left side of the screen here. So first, the researchers, what they need to do is they need to work out the risk for each group. So they're the numbers in the red circles that you can see. So you don't need to know the equation, but for this, they just divide the number of people impacted in the group, so the number of people that died, by all of the people in the group. So in our placebo group, we've got 100 people, 4 people died, so that's a risk of 4% for the placebo group. In our exposure group, so that's the drug group, 3 of the 100 people died, so the risk of death for the drug group is 3%. Again, the equation doesn't really matter, but I always just like to go over it. So that's our risk. So the first way a paper might display the results is with the absolute risk reduction at the top there. So this is basically what this means. It's just the number of percentage points that the risk goes down with the intervention or the drug. So the risk of death in the placebo group is 4% minus the risk of death in the intervention group, 3%. So that's a 1% difference. So the absolute risk reduction is 1%. And so what this might say in a paper is that the use of this drug reduced the risk of death by 1%. Sounds easy enough. So the second way a trial might report the results is by relative risk reduction. So the relative risk reduction represents the difference in death rates expressed relative to the control or the placebo. And again, it's usually displayed as a percentage as well. And again, there is an equation, but I just think of it as not as a difference in percentage points like our first example was, but the amount of difference between the 2 groups. So 3 is 75% of 4, right? So the difference between a risk of 3% and 4% is 25%. So think of it as if you were sale shopping and an item was reduced from £4 to £3. That's a 25% reduction. So that's what that means basically. So a paper might express this by saying that the risk of death was reduced by 25% in the drugs group relative to the control group. So hope you're all with me so far. So the third way is with the relative risk, and this one I think is probably the most common. Especially if you're looking at systematic reviews and things, they'll usually use the relative risk to express the results. So the relative risk is a ratio, so it's not a percentage, it's a ratio, of the probability of death occurring with the new drug versus the probability of death occurring without the new drug or placebo. So the difference here is that we're not looking at the we're looking, sorry, I'm getting all confused with myself. We're looking at the probability of death happening, not the reduction of risk or the reduction of death like the other ones do. So again, the equation isn't important for now, but basically it's dividing the risk of our drug group 3% with the risk of our comparison 4%, and then that leaves us with a risk ratio of 0.75. So to translate that into real world language, this tells us that patients who took the intervention drug are about 75% as likely to die. So I hope that makes sense. And then finally, the results in a randomized control trial might be displayed as number needed to treat. So this is a statistical concept, but it's quite intuitive because we know that not everybody was helped by the drug. People still died in the drug group. But also not everybody even needs the drug. You know, people in the placebo group didn't die. So the number needed to treat, what this is, it works out the number of patients that we need to treat to prevent one additional bad outcome. The equation is to divide 1 by the absolute risk reduction, not really important, but we're left with 100. So what this tells us, if you see this in a paper and the number needed to treat is 100, what that means is that for every 100 patients taking the drug rather than the placebo, 1 death will be prevented. So hopefully that's, you know, if this is the first time you've heard of any of these, that's going to probably blown your mind. So, you know, do feel free to ask questions at the end. But to be honest, even myself, I don't know these off by heart. Absolutely not at all. I have to look them up every single time. So fear not with that. So I'm actually just going to quickly simplify the relative and absolute risk reduction, and also just highlight how different expressions can make results seem a lot bigger or a lot smaller than they might actually be. So on the screen, I've got a completely fictional carrot example that I used to demonstrate this. So we've got 2 groups of 100. In our first group, everybody ate carrots, and in our second group, nobody ate carrots at all. So in our first group, 1 person had a heart attack, so 1% of people had a heart attack. In our second group, 2 people, so in the no carrot group, 2 people had a heart attack, so 2% of people had a heart attack. So the relative risk would be worked out by comparing the 1 and the 2% and saying that people eating carrots are 2% more like 2 times more likely to have a heart attack, or eating carrots reduces your chance of having a heart attack by 50%, which is technically true. But really it might be that, you know, first of all, eating carrots might not be as effective as it sounds because we're told the percentage and not the actual numbers, that it's just 1 person versus 2 people. But also, you know, these results could just be down to chance because the numbers are so small. Therefore, the fact that it was only an actual 1% point difference overall is helpful when it mentions that in the results too, and that's then called the absolute risk reduction. So if a paper is making a claim about a percentage in reduction of risk, have a look to see if it's the relative or the absolute risk reduction it's using, and if it's relative, it just might be a little bit more misleading really. And then the number needed to treat, so in this research it would be 100 again, because 100 people would need to eat carrots or a whole carrot-based diet to prevent 1 person from having a heart attack. So the next thing that we want to know is once we see these results, we want to know if the results would still be true if the research was done again, if it was repeated loads of times even, or was it all just down to chance? Because there's always a possibility that results just happen by random chance as well. Never forget. So there are two statistical factors that are mentioned in critical appraisal checklists that are really important for us to answer that question. And these are the p-value and the confidence interval. And if you've ever read a paper, you'll have seen them a million times. So I've got a little fictional study. So the excerpt's at the bottom, so I can demonstrate what these do. So we've got our results, which I'm going to read out to you. Results show that exercise is more effective than diet in preventing heart attack. And then following that is a bunch of numbers and symbols and brackets, which don't really mean a lot if you're not familiar with p-values and confidence intervals. So you'll have definitely seen this in a paper before and probably just ignored it. So now I'm going to try and explain what these mean. So first of all, the number that I've highlighted is 1.78, and that is the results based on relative risk. So we've just seen what relative risk means, and so this is, just how a paper might express that. So I've got a little kind of demonstration of that result laid out on a little visual. So our result is 1.78, which is displayed as that green dotted line on the chart there. A result of 1 would mean that there was no effect. So that's displayed as the red line on the chart. So if the relative risk was 1, just 1, that would mean that healthy diet and exercise are equally effective or ineffective as each other in preventing a heart attack. There's no difference in effect between those two treatments if the result was 1. Our result is 1.78, so it's more than 1. So in this case, and if you can see, it says favors healthy diet on one end and favors exercise on the other. So our result 1.78 means that the results favor exercise in preventing a heart attack, just like the result statement tells us. If the results were less than 1, so on the left line of the line of no effect, left side of it, then those results would favor a healthy diet over exercise in preventing a heart attack. So that's what the result means. I also want to mention that the closer the result is to 1, so let's say it was 1.5, so a little bit closer. So the closer that it is to the line of no effect on any end, in any direction, that means kind of the less effective the results were. So the further away it is, the more effective exercise will be. But the closer it is to the line of no effect, it starts losing its effectiveness really. So when a paper makes a conclusion about this difference in outcome and displays its results, that will then be followed by a p-value usually. So I've just highlighted that in the little box here. So a p-value is a measure of the probability that this result just occurred by random chance. So think of 0.05 as a percentage, and as a percentage that would be 5%. So a p-value of 0.05 means that there was a 5% probability that these results, our 1.78, just happened by random chance. And that's good, right? So the number 0.05, it's a little bit arbitrary again. Lots of things seem to be in statistics, but it's generally considered the cutoff. So anything above 0.05, so above 5%, is now considered unreliable. So the results were just down to chance. So they're no longer significant really. So we want our probability that the results were down to chance to be 5% or less. So we always want that number to be 0.05 or less. So I hope that's clear. Let's say that the p-value was higher. Let's say that now it says 0.06. Then that previous sentence, it shouldn't really be claiming anymore that exercise is more effective than diet, because now it might not be, because now the chances that it was down to chance are higher. And because 0.05 is the cutoff, we can't rely on that anymore now. So it's no longer statistically significant. If the p-value was 0.06, which you'll see in some papers or higher, then instead that result statement should say something along the lines of, in the case of exercise being more effective than a healthy diet, the results were not statistically significant. Or it could also say something like, exercise does seem to be more effective than a healthy diet, but the results weren't statistically significant. So it shouldn't be claiming any kind of significance with the p-value being higher. This is quite a general rule of 0.05. You will definitely see some studies, and I'm not really sure of why this happens, where it is okay for the p-value to be higher. Certainly not clinical trials though, but there might be other types of studies where the p-value can be a little bit higher. But just for the purpose of this, we'll always just assume it should be 0.05 or less. So next we have confidence intervals. So that's the next part in that bracket, all that gibberish. So confidence intervals are important because a study, it doesn't recruit a whole population, of course, it only recruits a small sample. So that means that if the study was repeated loads and loads of times with other people in the population of interest, you wouldn't get the exact results each time. You know, the results wouldn't always be 1.78 exactly, you know, that would be impossible. So a confidence interval range is basically, it's a range of an upper and a lower limit, so that if the research was repeated, yeah, it wouldn't always be 1.78 the result, but it would be somewhere within those limits, at least 95% of the time. That's important. It's always, confidence interval range is always 95% of the time, because that other 5% could have been down to chance with our p-value. So let's have a look at our example. So we can see the numerical confidence interval range is highlighted, the yellow highlighted. So that's 1.66 to 1.93. And then I've represented that on the chart above it as the blue horizontal line, and that covers those numbers roughly. I've just kind of played it by eye. So you can still see the green dotted line where the results, the 1.78 landed as well. So what's important here is that the confidence interval range is always above 1. It's always above the line of no effect, right? So if that research was repeated, then the result, yeah, it wouldn't always land on 1.78, but it would land somewhere between those two numbers. So somewhere on that blue bar range, which means that the results will always be in favor, well, 95% of the time, it will be in favor of exercise being more effective than a healthy diet. If within that range the number crosses 1 and lands in, you know, -1, so let's say our new example is that, you know, we've got 0.66 to 1.93, then that means that if the research was repeated, then the results might land on 1, and that implies that neither intervention is effective or equally as effective or ineffective. So we've got the line of no effect. And then, of course, if it crosses 1, then in some instances, if the research was repeated, the results might actually favor a healthy diet instead. So in that case, where the confidence interval lands on 1 or crosses 1, the result statement, again, it wouldn't be able to claim that exercise is more effective, because it might not always be. The next time you do that exact same trial, it might land on healthy diet being more effective. It might land on the line of no effect. So the confidence interval range, we don't want that to cross the line of no effect. So just to recap, so if a paper is claiming statistically significant results, then the p-value should be 0.05 or less, and the confidence intervals should not touch or cross the line of no effect. So we've just seen that the line of no effect was displayed as 1 in our previous example. 1 is the line of no effect. And that's the case for binary data. So that's where a result can be one thing or another. So people either die or they don't, you know, or survive or don't. Whereas for continuous data, so where the results are measured on a scale of some sort, like maybe pain severity or weight loss or so on, then the line of no effect, it's 0. It's 0, and it'll say 0 instead of 1. But first of all, the research will always point that out, so you don't need to make any extra effort. And it means the exact same thing. So even if it is 0 instead of 1, crossing the line or landing on the line of no effect produces non-statistically significant results. It's just something to be aware of. Right, so I've just got a few questions again. I'm not going to make you shout these out, so I want you to have a little think about these, and I'll tell you the answer, just to make sure that everything's kind of slowly going in. So the first question, how do you know if the follow-up rate of a trial was long enough? Do you look at the power calculation of over 80%? Do you use your own clinical judgment to say, that was long enough, maybe that should have been a bit longer? Or do you rely on what the researchers have said in the paper? So if they said the follow-up rate was long enough, then we'll just trust them. So have a little think about that. And I'll tell you the answer in a couple of seconds. So the answer to that would be use your own clinical judgment. There isn't any kind of statistical equation to work out the follow-up rate, and you shouldn't really always rely on what a researcher says, although, you know, hopefully they're not lying to us, but do determine by yourself if you think that the follow-up rate might have been longer because you have, of course, experience in that, then, you know, your say is as important as anybody's. So do keep that in mind. The next question is about the number needed to treat. So what is the number needed to treat? Is it the number of people that need to take the intervention to prevent one bad outcome? Is it the number of people that need to take the placebo to prevent one bad outcome? Or is it the number of people out of 100 that should receive the intervention? So let you think about that for a second. Lovely. So the answer is that the number needed to treat is the number of people that need to take the intervention to prevent one bad outcome. I've thrown you a little bit here because all of the examples I've used with number needed to treat have been out of 100. So it's always been 100 people need to take the intervention to prevent one bad outcome. But that just happens to be the examples that I use. The number needed to treat isn't always 100. It can be any number depending on what the results was of the trial. So it might be that only 50 people need to take the intervention to prevent one bad outcome. So. Next we have, what should the p-value be? Should it be 95%? Should it be 0.05 or less? Or should it be over 0.05?
That doesn't work. It's not there, Anne, because I've just been on it.
So the answer is that it should be 0.05 or less. The 95% is the confidence interval range, although the 0.05, you can kind of interpret it as a 5% as well. So 0.05 or less. And then the last question I've got for you is, which of these following statements about confidence interval ranges is true? Is it that they should cross the line of no effect for statistically significant results? Is it that they should always be over 1? Or is it that the true result, so if it was repeated, the true result lies within that range 95% of the time? And so the answer to what a confidence interval range is that the true result lies within that range 95% of the time. So the true result is the phrase that's used quite a lot. I haven't really introduced it by now. I've been saying if the result was repeated and repeated, well, that just means the true result. And it would be within that range, not all of the time, it is 95% of the time, but that's statistically significant. So that's absolutely fine. In the example that I used, it was always over 1, but that was just for that particular piece of research, my fictional study, I think it was. In some cases, it might be that the other intervention or the placebo is more effective, but just for a statistically significant result, if they are claiming that a placebo is more effective, the confidence interval range should always be on the placebo side, whichever side it is. And the same for if a paper is claiming that the intervention was effective, the confidence interval range needs to be on the intervention side of the line of no effect, the whole of the range. Lovely. So that's it. So so I can be honest and say that it's taken me ages to grasp all of that myself. And you know, if I am being honest, I still, as I said, need to look up most of it most of the time. So please don't be disheartened by everything that I've just thrown at you. As I said, I'm going to send the slides around, and I've popped some videos on the slides, and those by Sketchy EBM are really wonderful. They're like 5-minute little cartoon videos, and they explain all these different concepts really, really well. So I definitely urge you to have a look at those if you need a bit of a recap. And of course, this session is being recorded as well, so do pop back to that too. We've also got at the library, we've got absolutely loads of books about appraisal and statistics that are available to borrow from the library, but loads of them are online too. So if you've got an Athens account, if you don't have one, get one. But if you do, all the links that I popped in there, you'll be able to access those with your Athens account. So do make use of those. And then obviously I'm always at hand to help as well. So do get in touch with any queries. So yeah, so I'm very happy to answer any questions that anyone that might have now as well. I'm going to stop sharing my screen.
Can I just ask, with the p-values and the confidence interval, how do they calculate these without actually repeating?
How do they calculate the p-values? I have absolutely no idea. And I don't think for critical appraisal.
I just wondered how do we know that they're reliable figures? That's what I'm thinking.
Well, that's the thing. I mean, there's lots of like statistical tests and software and things that go into calculating p-values and confidence intervals, but that is not something that for critical appraisal you definitely don't need to concern yourself for that. Definitely.
Okay.
Thanks, Ramona. There's a couple of questions actually in the chat.
Oh, fantastic.
So we're being asked, is there any tool for power calculations?
So again, sorry.
Yeah, there's a few stats things actually about asking about access to SPSS, and I think that's probably another whole training package in itself that we maybe need to think about stats and intra-stats type.
So as I said, I'm not a statistician, so actually working out p-values, power calculations, all that stuff is way beyond anything that I can do. But we do have access to stats software at the library. Certainly at Salford Library, where I'm based, we have Stats Direct software. And I think that we are looking into getting a few more different packages on that as well. So you can definitely access stats software from the library. Yeah, definitely.
Lovely.
Hi, everybody. I'm
hi,
really
Heather.
sorry I'm
Hi,
late to the
Heather.
party. I've just been having a few little issues getting in. Thank you, Claire, for letting me in.
That's all right.
Can I just say, actually, R and I do have access to a statistician. So if anybody needs statistics support, we buy some support from the University of Manchester. His name's Calvin and he's absolutely brilliant. But if you're doing a project, you need to involve your statistician at the very beginning when you're planning your project. So the thing that statisticians find really difficult, and they don't particularly like it either, is when somebody pitches up with a database of data and says, can you do something with this? And they go, what was your research question? What was your plan? So it's really important that you involve them at the outset and don't turn up with a load of data and expect them to analyse it, because A, they don't like it, and B, it's not good practice.
that's really good to know. Thank you, Heather. And what is the name of the chap, the statistician?
You're best to go through R&I.
Okay.
Yeah.
Brilliant. Just
because it might change, but you know, if he's moved on or whatever, and if he's really busy, then they may actually have somebody else that they use. So if you go through R&I, that's best.
Brilliant. Oh, that's really good to know. Yeah, so anything more in-depth statistical that I've covered, definitely to R&I. But anything critical appraisal wise, obviously I'm more than happy to help.
I think it's useful to have some really basic stats training for appraising the literature, just so that you can actually have a look at the stats yourself, like you say, and just make sure that the stats are sound, because even if you don't have that stats knowledge, actually being able to just look at the stats and say, yeah, that looks like it's been done in a robust way.
Definitely, it definitely gives you a good idea. And because the critical appraisal tools, they do ask questions about p-values and confidence intervals and those more basic stats, that knowledge is definitely helpful to have. Yeah, I
mean, I think we make an assumption, don't we, if something's in a peer-reviewed journal, that actually stats are going to be fairly robust, but it's good to be able to actually cast an eye over it and being able to see that is something that we've got a little bit of background knowledge in.
Brilliant. Yeah, absolutely.
Lovely. So has anyone got any other questions about this session or any future sessions that they think would be, would be useful?
Done silence.
No.
Yes. Well, as I said, I'll send the slides around. There's a recording, of course, and if anybody has any other questions or want any follow-up sessions, anything like that, do definitely get in touch, and I'd be more than happy to help.
Thank you, Ramona.
No worries at all.
Absolutely brilliant. Really appreciate your help.
Oh, thank you so much for inviting me to come speak.
We might be inviting you again. I hope that's okay.
Yeah, definitely.
Yeah, I think there's a very good chance. We've been getting a lot of feedback from your sessions to say that people have found it really, really useful for that sort of starting point. So yeah, thanks very much for agreeing to do them.
Oh, well, thank you so much, everybody, and hopefully I'll see you all soon.
Yeah, thanks very much.
Lovely. Thank you so much. Bye.
Bye.
Thanks, Mona. Thank you.
Bye.
Bye.